Good afternoon to everybody. Welcome to this webinar on pyruvate kinase activation, update on clinical trial results across hemolytic anemias. My name is Nica Cappellini, and I want to give you some disclaimer before starting. The speakers are presenting on behalf of AGIOS Pharmaceuticals. This presentation discusses mitapivat, an investigational compound. The safety and efficacy of mitapivat has not yet been established, and there is no guarantee that mitapivat will receive health authority approval or become commercially available in any country for the uses being investigated. These are my disclosure, and the faculty is represented by Dr. Barcellini, a very well-known expert on the field of hemolytic anemias. Vilma Barcellini is working in Milan at the Fondazione Cagranda Ospedale Maggiore Policlinico. Edward van Beers, he is an expert on sickle and other hemoglobinopathies, working in Utrecht at the University Medical Center. And myself, I am professor of internal medicine at the University of Milan. This is the agenda for today. After a short introduction on pyruvate kinase function and mechanism, Dr. Barcellini will present us the result of pivotal clinical trials on mitapivat in pyruvate kinase deficiency. Then I will move to thalassemia, presenting the clinical results on activation of wild-type pyruvate kinase in thalassemia. And Edward van Beers will do the same, presenting preliminary finding in sickle cell disease. Just to keep you on the field, although all of you, of course, are very well experienced on that, I remind you that pyruvate kinase is an essential enzyme at the last step of the glycolysis, producing energy for the cells, transforming ADP to ATP. So it is a really essential and important enzyme. In normal condition with wild-type pyruvate kinase, the cellular demand are compensated by the production of ATP, which is produced enough to meet the demand. When the PK is mutated, causing a pyruvate kinase deficiency, the synthesis of PK is deficient, the cellular demand remains similar to a normal condition, and as a consequence of the deficiency of the enzyme, there is an inadequate production of energy, an inadequate production of ATP, which is translated in reduced red blood cell membrane integrity, increase RBC destruction, and this cause chronic hemolytic anemias. Another possibility is to have wild-type PK, but an increased cellular demand of energy, as it happens, for example, in some hemolytic anemias. In such case, with an increased demand of ATP, there is no possibility to compensate this demand, and again, the conclusion is damage, premature death of red blood cell, and hemolysis and anemia. So you can see a different scenario where PK play a major role. What mitapivat can do? Mitapivat activates wild type and mutant PK enzymes which, as I mentioned, act at the final step of a glycolysis to generate energy in the form of ATP. So this molecule may compensate the need of producing ATP. So with that very short introduction, I am very happy to introduce my colleague, Vilma Barcellini, for her presentation on mitapivat in pyruvate kinase deficiency, results of pivotal clinical trial. Vilma, the floor is yours.
Thank you, Nika, and thank you to the organizer to giving me the possibility to talk about mitapivat in pyruvate kinase deficiency. These are my disclosures, and this is the pathophysiology of PK deficiency, which is very simple because it is a chronic hemolytic anemia caused by mutation in the PKLR gene, which causes a reduction of PK activity or PK stability, inefficient glycolysis, and reduction of ATP generation. This results in a reduction of red cell membrane integrity and in increased red cell destruction, with consequent chronic hemolysis, anemia, hyperbilirubinemia, iron overload, and acute and long-term comorbidities and complications. They're shown very well in this slide. These are data from the 254 patients, and you see that iron overload is very frequently, 47% of patients, 23% needing chelations. We had 59% patients already splenetomized, 45% with cholelithiasis, and 40% having had cholecystectomy. Then we have several other complications: endocrine disease, thyroid disease, pulmonary hypertension, extramedullary hematopoiesis, aplastic crisis, liver cirrhosis, and also thrombosis that make diseases very similar to hemoglobinopathies. And I will focus on osteopenia and bone fractures, which are shown in this slide, with the prevalence of these two conditions, osteopenia and osteoporosis, as assessed by DEXA scans or by the medical history. And it is clearly shown that 58% of patients had osteopenia by DEXA, and almost 17 had osteoporosis by DEXA, while with the medical history, these percentages are clearly lower. So it's very important to perform this examination in these patients. The results of the DRIVE PK, which was the first study, a phase 2 study of mitapivat in patients with PK deficiency not receiving regular transfusions. And 50%, the 26 out of 52 patients, achieved an hemoglobin increase greater than 1 gram during the 24-week period. And all the hemolytic markers here are shown, reticulocytes and bilirubin, had a consistent amelioration. Most importantly, improvements in hemoglobin and in markers of hemolysis were sustained during the extension period, a median of 3 years and up to 42 months in some patients. Looking at bone mineral density, which was a concern in this category of patient, and also because mitapivat has an inhibitory effect on aromatase, the DEXA scan were stable over time during all the observation period, including the core period and the extension phases, and is consistent with the picture already observed at baseline. So this is not a concern of this therapy. On the basis of the results of the DRIVE PK, It was designed a phase 3 randomized double-blind placebo-controlled study aimed at evaluating the efficacy and the safety of mitapivat in patients with PK deficiency not regularly transfused. The key eligibility criteria were adults, age greater than 18 years old, 2 mutant alleles in PKLR gene, and at least 1 missense mutation. Again, in the exclusion criteria were excluded patients that had the homozygous mutations or the non-missense mutation that had been identified in the non-responder patients. Baseline hemoglobin should be lower than 10 and less than 4 transfusion episodes in previous years. Of course, adequate organ function, and among the exclusion criteria, splenectomy in the year before enrollment and the bone transplant. Patients have been randomized 1-in-1, mitapivat versus placebo, and there was an individualized dose escalation period. And this was done because in the TRIVE PK study, we observed that responses were found among several doses. So every patient had to find his individual dose. At the end of this period, found in the optimal dose, we have a fixed dose period of 12 weeks where patients were compared among the arm in treatment and in placebo. These are the characteristics of the two groups, 40 patients in mitapivat and 40 in placebo. They are completely comparable regarding age, median, range, sex, race, geographical region, so nothing particularly to highlight. And more importantly, the baseline characteristics of the disease were comparable regarding hemoglobin values, 8.6, 8.5, ferritin, hemolytic markers, indirect bilirubin, LDH, haptoglobin, reticulocytes. Importantly, prior splenectomy was comparable and also prior transfusion need. Other characteristics of the populations like cholecystectomy, chelation, DEXA score, and category of PKLR mutations were equally distributed in the drug group and placebo group. And these are the very nice results, because mitapivat met the primary endpoint demonstrating a higher hemoglobin response rate compared to placebo. Hemoglobin response was seen in 40% of patients treated with mitapivat compared to 0 patients in the placebo group. Here is the same results, very clearly shown the hemoglobin values. In blue, the patient treated with mitapivat, in gray, the placebo group, and the difference is highly significant. Consistently, we had in the treated group a reduction of bilirubin and LDH, and in the placebo group, no significant change. And lastly, the haptoglobin and reticulocyte counts have consistent behavior with increase of haptoglobin in treated patients and reduction of reticulocytes again in mitapivat treated group. Hemoglobin response was seen across all predefined patient subgroups. That means that the response was observed regardless screening, hemoglobin screening, baseline hemoglobin, category of mutation, age screening, sex, race, geographic region, prior splenectomy, prior cholecystectomy, or prior chelation therapy. Importantly, and there was a statistically significant improvement in change from baseline to week 24 in these two dedicated patient-reported outcomes, that is PKDD and PKDIA, which is a score specifically designed for patients with this disease and hemolytic conditions. And we found in the mitapivat group a reduction in -5, -4 of these patient-reported outcome compared with placebo. And in this case, the minus is equivalent to a greater improvement of the burden of the disease. Regarding safety, we had several emergent events which were equally distributed in the mitapivat and placebo group, and more importantly, there were no treatment-related adverse events leading to dose reduction, interruption, or discontinuation of study drug. There were no deaths in both groups. This is the list of all the adverse events, mostly nausea, headache, that were, and all the others very common adverse events that, more importantly, are equally distributed in mitapivat and placebo groups. On the basis of these interesting results, there was the ACTIVATE-T study was designed in a small group, in a subset of PK patients that are transfusion dependent. This is an open label study aimed at evaluating the efficacy and, of course, safety of the drug. The criteria of inclusion-exclusion are quite similar to those previously reported, just to highlight that patients should have had 6 transfusion episodes in the past year before enrollment. The complete records of transfusion history should be well documented. And again, the exclusion criteria were those particularly mutations that are associated with poor response. As observed before, we had an individualized dose escalation period and a fixed dose during which all parameters had been evaluated. These are the characteristics of the patients. The age is 36 years with a very wide range. Half and half patients are distributed with age lower or greater than 35 years. There is a little prevalence of females and nothing to say to race and region. Baseline characteristic underlying the severity of the disease. Hemoglobin is 9.2, the median. Ferritin is very high, notwithstanding most patients, 88% had pre-alkylation therapy. Again, a great majority, 77% of patients had been splenectomized, and that means that they are still transfusion dependent after splenectomy. 85% cholecystectomy. The DEXA score are consistent with those described in the population, as well as the genetic setting. Importantly, the number of transfusion episodes are really high. There are 9 transfusion episodes as a mean, and the number of units transfused as a mean are 16. So it's really a burden of transfusion need. Again, I underline notwithstanding splenectomy. These are the very nice results that show that mitapivat met the primary endpoint, demonstrating a significant reduction in transfusion burden. This occurred in 10 patients, 37%, that had a reduction greater than 33%, which is considered clinically significant. And 9, 33, achieved a greater reduction, more than 50% reduction in the total number of units transfused. Again, and more interesting, 6 patients, 22%, achieved transfusion-free status during the 24-week fixed dose periods. And 3 of these 6 patients achieved hemoglobin concentration in the normal range, at least once, again in this 24-week fixed dose period. This is another way to say the same results, which is the transfusion need historical for mean for episodes on treatment 2.8 with a 39% reduction, and the number of units transfused 7.6 to 5.4, so 37% reduction, which is really clinically significant. The number is not so huge because this is a small setting of transfusion-dependent pyruvate kinase deficiency, but again, the benefit of mitapivat is observed across all the different patient subgroups, age, sex, race, mutations, baseline individual transfusion trigger, historical transfusion burden, number of episodes and number of units transfused, and also a prior splenectomy for the few patients that were not splenectomized prior to enrollment. The PKDD and PKDIA again showed an improvement. I remember the minus sign means improvement. So from baseline, we observed a change that is minus 5.3 and minus 4.9. So it's really an important change for the patient-reported outcomes of this disease. And this was even more magnificent during the fixed dose period for 24 weeks, reaching minus 9.1 for the PKD-IA reported outcomes. Nothing new on the adverse events, the majority grade 1 or 2. 2 patients had a grade 3 with the increase of transaminase, joint swellings, but there were no adverse events leading to death, no patient discontinued, interrupted, reduced, or had some problems with the drug. So in summary, these 2 studies, the ACTIVATE and the ACTIVATE-T, show first that the primary endpoint was met with 40% of patients randomized to mitapivat, achieving a sustained hemoglobin response compared to 0 patients in the placebo groups. Treatments improved not only hemoglobin concentration, but also other pre-specified secondary endpoints, that is marker of hemolysis, and these novel PK deficient specific patient-reported outcomes. In the small setting of the transfusion-dependent study, the primary endpoint was again met with 37% of patients treated with mitapivat achieving a reduction in the fixed period dose, and 22 receiving the drug, reaching a status of transfusion-free during this fixed dose period. Mitapivat was well tolerated, a consistent safety profile with those data already published, and most commonly reported adverse events were headache and nausea. So the drug has the potential to be the first disease-modifying drug therapy applicable to a broad population of pyruvate kinase deficiency patients. And I thank you all for your attention, and I give the rest of the meeting to Nika Capellini. Thank you.
these are my disclosure. Today, the thalassemia syndromes are classified accordingly to the transfusion burden to make simple to care of the different and heterogeneous conditions. So we may distinguish the severe form of thalassemia, which are now known as transfusion dependent, and that this definition include the classical beta thalassemia major or beta thalassemia severe form, usually beta 0. It includes also the severe hemoglobin E beta thalassemia and the non-deletional hemoglobin H, which are alpha thalassemias, or survived hemoglobin Bart's eye drops. These are the extreme form which are not, let's say, surviving without regular long life transfusions. On the other extreme of the arrow, we have the carrier or the thalassemia minor, including alpha thalassemia trait, beta thalassemia trait, or even homozygous hemoglobin EC or homozygous hemoglobin E or C. These are transfusion independent. These are simply carrier, which must be recognized for genetic counseling, but clinically are not relevant. In between these two extremes, there is a huge spectrum of non-transfusion dependent thalassemia. And this spectrum, this umbrella, include patients who are clinically relevant, who may require occasional transfusions or intermittent transfusion, but not as frequent as in the severe form. And under this definition, transfusion-dependent patients, we include the beta thalassemia intermedia, the hemoglobin C beta thalassemia, the mild hemoglobin E beta thalassemia, and hemoglobin H with beta thalassemia trait or deletional or non-deletional form of hemoglobin H. So we include under this definition also alpha thalassemia patients. Looking at the clinical behavior of these two conditions, we may underline that some complications are common to TDT and non-TDT patients, especially those due to iron overload because of transfusion or because of increased iron absorption. But in NTDT, so in those who are not regularly transfusion, we may have complications which are mainly due to the underlying thalassemic erythropoiesis, which is an ineffective erythropoiesis, responsible, for example, of extramedullary hematopoiesis masses, gallstone, hemolytic anemia, thrombosis, and so on. The introduction of transfusion, or at least regular transfusional scheme, which more or less occurred in the 1965, something like that, changed actually the survival curve of these patients, because before, for the cohort of patients who were born before the 60, the survival expectation was less than 10 years. After the introduction of regular transfusion, actually they start to survive longer, although there was an important issue due to the iron overload related to transfusion. Actually, the situation furtherly improved when the iron chelation was made available, and that was in the second part of 70, when the sferrioxamine became a standard practice, but even more improved significantly when in the late 90s, it was possible to measure the iron load in the liver and in the heart through the MRI. And that allowed to standardize better the iron chelation. And moreover, in 2005 or around that time, the sferrioxamine was substitute in large part by oral iron chelator, and that was a significant improvement. Nevertheless, despite significant advances, there are challenges which are still present in the management of transfusion-dependent thalassemia. For example, limited access to treatment, cost of treatment, convenience of treatment and adherence, because nevertheless, although oral, the iron chelation is quite demanding, in some patients also the adverse event and the lack of efficacy. And that's remain unmet needs. Looking at the non-transfusion dependent thalassemia patients, even if they are not regularly transfused and they don't suffer of iron load due to transfusion, nevertheless, we, in collaboration with the Middle East colleague, found that several complications are quite frequent across the different age quartiles. We extrapolated from a large study, the Optimal Care study, 120 patients, treatment naive. They never received any transfusion, they never received chelation, they never received hydroxyurea. And you can appreciate that several complications, which I already mentioned before, were progressively increasing according to age. So even in non-transfusion dependent thalassemia patients, there are significant clinical burden due to complication appearance. And also we try to compare the thalassemia-related complication in alpha thalassemia compared to the optimal care patients, so the beta thalassemia patient. And you also can appreciate that hemoglobin H, so alpha thalassemia, may have quite significant complications. Moreover, I have to underline, as I already mentioned, that either due to iron blood transfusion or due to increased iron absorption, the iron overload is a major contributor to multiple morbidity in NTDT patients. And there are several studies very well conducted which underline the risk of complication due to iron overload, such as pulmonary hypertension, endocrinopathy, renal disease, which were very much neglected, hepatic fibrosis, and so on. Notable, there is an absence of cardiac siderosis in non-transfusion dependent thalassemia, despite a high level of liver iron concentration, which unfortunately liver iron concentration may lead long-term to development of hepatocellular carcinoma. Recently, in a small cohort of patients, but with a quite long follow-up, we were able to show that the morbidity-free survival goes with the hemoglobin level in non-transfusion dependent thalassemia patients. Patients who have hemoglobin more than 10 gram or equal 10 gram, they tended to be morbidity to survive without morbidities for several years compared to those who have hemoglobin level below 10. And we showed that variation of 1 gram deciliter in hemoglobin level are independently associated with the number of morbidity in NTDT, which suggests that an improvement of hemoglobin is impacting significantly on survival free of complication, and of course on quality of life. Why we considered the potential use of mitapivat in thalassemia? The hypothesis is that activating the wild type of pyruvate kinase, we may actually correct the let's say, pathophysiological background observed in thalassemia, which start with an imbalance of alpha and beta globulation. The free globin chains precipitate, forming hemichrome. They cause oxidative damage. Oxidative damage is responsible of hemolysis, ineffective erythropoiesis, anemia, and also impact on a dysregulation of iron metabolism. So what mitapivat could do is to compensate the let's say erythropoietic stress, increasing the ATP production. And that was the hypothesis for designing a study, because we can expect to have a reduction of ineffective erythropoiesis, a reduction in hemolysis, and as a consequence, a reduction in anemia and on iron overload. So that was the hypothesis, but was also proved in a mouse model of beta thalassemia, where mitapivat ameliorated ineffective erythropoiesis, iron overload, and anemia. So with this background, a phase 2 open label multicenter study investigated the efficacy and safety of mitapivat in non-transfusion dependent thalassemia patients, either beta and alpha. This is the study design. The core period was lasting 24 weeks. 6 weeks were on mitapivat 50 milligram twice a day orally. The other 18 weeks with 100 milligram of mitapivat twice a day orally. And then, of course, there will be an extension period and safety follow-up. The key inclusion criteria were beta thalassemia plus alpha globin gene mutation, because we may have a co-inheritance, hemoglobin E beta thalassemia, or hemoglobin H disease. Hemoglobin should be less than 10 grams per deciliter, and we are including non-transfusion dependent patients. The primary endpoint was the hemoglobin response, defined as an increase of equal or more than 1 gram deciliter from baseline at any time between weeks 4 and 12 inclusive. The secondary and exploratory endpoints were sustained hemoglobin response, delayed hemoglobin response, markers of hemolysis and erythropoiesis, and of course, safety. Quickly, these are the demographics and basic baseline characteristic. There was more females than males. The median age was 44 years. And I want to underline that together were 20 patients, 5 alpha thalassemia and 15 beta thalassemia. The median hemoglobin baseline was 8.4, and as marker of hemolysis, we have an increase bilirubin level, an increase LDH, and erythropoietin. The median was 79. The genotype were for beta thalassemia, 6 were beta thalassemia intermedia, 3 intermedia plus duplication of alpha gene, and 2 were trait plus some mutation which made the phenotype typical of thalassemia intermedia. 2 were hemoglobin inhibitor 0 thalassemia, and 5 alpha thalassemia, 2 deletional form and 3 non-deletional forms. Here are the results. So mitapivat met the primary endpoint of hemoglobin response in 80% of the overall patients. And if we look separately alpha and beta, 5 out of 5, 100% of alpha thalassemia responded, and 73% of beta respondent. So that was the achievement of the first primary endpoint. As for the secondary endpoints, there was a sustained hemoglobin response in terms of increase of hemoglobin concentration at equal or more than 2 assessment between week 12 and 24, and again the alpha thalassemia responded, achieved the sustained response at 400%, and the mean hemoglobin change from baseline over a 12-week interval from week 12 and 24 was overall 1.3 gram, in thalassemia 1.2, and in beta thalassemia 1.3. So the improvement in hemoglobin were rapid, maintained over the duration of the core treatment period, as you can observe in this graph. Moreover, I want to show the improvement of markers of hemolysis and erythropoiesis in both alpha and beta thalassemia. You can appreciate total bilirubin, LDH, and erythropoietin, either in alpha or beta thalassemia, improve quite significantly. In terms of adverse event reported, I should say that nothing was particularly worried or due to the compounds. I just summarize in this slide the safety profile. First of all, the adverse event, the leading to study drug discontinuation was not treatment related, and there were no deaths during the study. You can see that some patients, quite in a large proportion, experience initial insomnia, diarrhea, abdominal distension, but all these were manageable. 5 patients had more than grade 3 adverse event. One was initial insomnia, one arthralgia, but none of them, as you can, as I already mentioned, was leading to interruption specifically for a drug-related complication. 3 patients had dose reduction due to abdominal distension and dyspepsia. One interruption was because of a vertigo positional, doubtfully due to the drug, and one was discontinued because renal impairment of grade 3. So in conclusion, this is the first clinical study evaluating pyruvate kinase activation as a therapeutic option in alpha and beta thalassemia. And this is the first drug trial aimed at evaluating treatment also in alpha thalassemia. The study met its primary endpoint and demonstrated a sustained hemoglobin response and improvements in hemolysis and in effective erythropoiesis in patients with alpha and beta thalassemia. Mitapivat was well tolerated, and the safety profile was consistent with previous study, especially those conducted in PK deficiency. 17 patients continued to the extension period of the study, And by April 2021, 16 patients remain on study drug. Mitapivat, through activation of wild-type PK, may represent a novel therapeutic approach for patients with alpha and beta thalassemia. And at present, 2 pivotal phase 3 trials, ENERGIZE for non-transfusion-dependent thalassemia and ENERGIZE-T for transfusion-dependent thalassemia, are initiated. Actually, they are in enrollment, and these are the 2 study design. The randomization will be 2 to 1. A large number of patients, 171 for NTDT and 240 for TDT. The inclusion criteria will be, of course, so far adult patients aged more than 18, and the characteristic will be those we already use for the definition of non-transfusion and transfusion-dependent patients. And I thank you for listening, and now I'm pleased to introduce my colleague, Edward van Beers, who is going to present the activation of wild-type PK in sickle cell disease preliminary finding.
Thank you very much, Professor Cappellini, for a kind introduction. And thanks to Tiff to have me here and to present on the results in sickle cell disease, the first findings of mitapivat. So, as some background, for decades it's known that elevated 2,3-DPG levels promote polymerization in sickle cell disease. Some papers back in the 60s from Poisson showed that there's a relation between high 2,3-DPG levels and worse outcome in sickle cell disease. And it comes because polymerization of deoxyhemoglobin S results in most of the sickle cell disease related outcomes such as vaso-occlusion and hemolytic anemia. Here you see a graph representing the paradigm of the pathophysiology in sickle cell disease, where normal oxygenated conditions, the red cells freely flow through the vasculature, and upon deoxygenation, hemoglobin is polymerized and red cells get stuck. Of course, there's a lot to say about it, and it's much more complex than this, but this is the simple way to put it. And given the fact that deoxygenation of sickle hemoglobin is so pivotal in the pathophysiology of sickle cell disease, that then also oxygen affinity is very important. Here you see a graph which many of you have seen in medical school already, which you might have forgotten it, is that this is the oxygen saturation of hemoglobin, and this is the partial pressure of oxygen. And when oxygen falls, hemoglobin will release more and more of its oxygen. And when 2,3-DPG is going down, or when patient more alkalotic and pH is higher, hemoglobin will retain the oxygen much more, which in theory is very beneficial in sickle cell disease. And when the patient becomes more acidic and has more glycolytic intermediates such as 2,3-DPG, the oxygen affinity is going down and hemoglobin desaturates much easier, which promotes sickling. Here we see how a PKR activation might jump in. You have seen this graph before, I think the left one, which shows glycolysis, where glucose is in a number of steps is produced into pyruvate, which of course normally goes into the mitochondria, but in red cells it ends there. And it's the only source for ATP in red cells, therefore it's so important. And it's also important because the metabolites of glycolysis 2,3-DPG drives the oxygen affinity, as you saw before. So here we get a double punchline to reduce severity of sickle cell disease. One is increasing oxygen affinity. There are some other drugs who do less or more the same in a different way. But here we also get the addition, the ATP bonus. And that's very important because the energy metabolism is very important. For instance, the ATP-dependent calcium pump needs ATP to constantly export calcium from the cells. If it doesn't do this, increased calcium will do a lot of bad things in the red cell, among others, activating the Gardus channel, dehydrating the red cells profoundly and producing the dense cells many of us know as a negative marker of outcome in sickle cell disease. So a double bonus if you were able to improve pyruvate kinase activity in sickle cell disease. So let's move on from hypothesis to real life. This is a study from the NIH. Suiletain is the principal investigator of this very interesting study where they, it's an open label phase 1 study where they enrolled 15 to 25 patients, adults with homozygous sickle cell disease, and no transfusions or changes in hydroxyurea or L-glutamine were allowed in the last 3 months before enrollment. Here you see the design of the study. There was a screening period of less than 2 weeks, and then a dose increase from 5 mg BID to eventually 100 mg BID for patient 8 to 12, and the first 7 patients were escalated to 50 milligram BID. After that, there was a dose taper and a safety follow-up. Primary endpoints of the study were safety and tolerability, changes in hemoglobin and hemolytic markers. Secondary endpoints, of course, 2,3-DPG and ATP, the 2 markers which are so important for the pathophysiology and the oxygen dissociation curves. Here you see the baseline results of the characteristics of the enrolled patients. 12 patients were enrolled. The mean age was 40 years. About half of them male. Most had African or African American background. Most were using hydroxyurea on a stable dose, and 1 was using L-glutamine on a stable dose. And as said, 5 patients escalated to 100 mg BID. Mean hemoglobin level was 9.5, absolute retic count around 200, and total bilirubin 2.2, and slightly increased LDH, as we know from sickle cell disease, around 250. F percentage was 18%, it's quite high. Here, first results on ATP. You see here a dose relation with increasing dose. Also, the amount of ATP increases. And 2,3-DPG also decreases alongside with the increase of ATP. So here is happening what we would expect from mitapivat. But it's also interesting because this is another disease where the drug does this on the wild type pyruvate kinase but more importantly, what happens to hemoglobin? And here you see that in the patients who are on 50 milligram BID, we see a very clear dose increase to mean increase, a maximum hemoglobin increase of 1.3. About 50% had an increase of about more than 1 gram per deciliter, and the maximum hemoglobin increase in patients that responded was around 2. Here you see that in most patients there was a clear decrease in hemolytic markers. Bilirubin went down. And I would just want to emphasize this group with the 100 milligram BID was very small. So I think it's too early to say something about this. The error bars are quite wide, but as well as in 50 as in 100, you see a clear decrease in bilirubin. Change from baseline lactate dehydrogenase marker of intravascular hemolysis is also there, a drop of 50. And I think also very important is the reduction in young red cells, which is about 60 to 40 in both dosage groups. So taken together, less hemolysis, slight increase in hemoglobin, and some very clear. Here you see the safety profile of the treated patients. And first, I want to mention the VOCs because they drive the grade 3 adverse events, pain, and VOC. But you have to know that no VOC happened during dose escalation. One VOC happened during dose taper, and 2 happened during the safety follow-up study, safety follow-up, and also due to known VOC triggers. So on drug, we didn't see these adverse events. So besides this, I think the safety profile was pretty the same as we saw in the other studies. I was an investigator on the Activate and Activate 2, and I recognize all these side effects as well. And many of these are also related to the disease itself. So I think we need a phase 3 to find out finally, but at least we didn't see any new safety signal. So, in summary, this study provides a first proof of concept that the mitapivat does in sickle cell disease what it does in other red cell diseases presented today. ATP goes up, 2,3-DPG goes down, with the first signal that this, in theory, very important mechanism is working because hemoglobin goes up in 50% of the patients, at least for 1 gram per deciliter. And we see a reduction in hemolytic markers. We didn't see any VOC during the dosing, and only after reduction of the dose taper, or during the safety follow-up, we saw VOCs. So I think this is very encouraging. Extension study is going on in NIH and other sites in the world. Study is very well tolerated, where there were no safety signals. So I think there's room to move on to a larger 2-3 phase study, and is already on the go. It's called Rise Up. It's an operational seamless study, phase 2 part, where the best dose is will be selected, either 50 milligram BID and 100 milligram BID with matched placebo, and in a larger group in the phase 3 study. Primary endpoints are hemoglobin response, defined as a 1.0 gram per deciliter increase in average hemoglobin concentration during weeks 24 and 52. And more importantly, I think, annualized rate of sickle cell related adverse events or events. So enrollment criteria are, I think, pretty interesting, because patients from 16 years and older are eligible. So some teenagers can enroll. You need to have some sickle cell crisis in the last 12 months. It's widely defined, so look up. It doesn't only include sickle cell crisis per se. Hemoglobin 5.5 and between 5.5 and 10.5. Patients on other new drugs, such as voxelotor and crizanlizumab, are excluded. Treatment hydroxyurea is allowed, and here in the sickle cell disease is also included. SC patients are also allowed. So this is, I think, a more broad room for enrollment from patients, and where I am at least looking very much forward to the results of this study to see whether it can as successful as in pyruvate kinase deficiency and thalassemia. Thank you very much. Hereby, I want to give Professor Cappellini the word again, and thank you very much for your kind attention.
Okay, so we reach the end, and I just would like to conclude the webinar with a few outlines. PK deficiency is a lifelong hemolytic condition associated with serious complications and with no approved therapies. The phase 3 ACTIVATE and ACTIVATE-T studies met their primary and key secondary endpoints, demonstrating that the oral PK activator mitapivat produced significant clinical benefits and improvement in quality of life in adult patients with PK deficiency. Clinical trial in pediatric patients with PK deficiency is on plan for 2022. Activation of wild-type PK with mitapivat demonstrated proof of concept and clinical benefit in thalassemia and in sickle cell patients, and pivotal trials for both conditions are already starting the enrollment in 2021. PK activation with mitapivat represents a potential therapeutic mechanism that may improve clinical outcomes across a range of hemolytic anemias. So with this preliminary observation, the results from the ongoing trial will be providing us a new insight, and definitely we will see how these compounds may be used in such hemolytic condition. So now we are open to take any question. So please submit your question. The faculty are present, and we will be happy to answer to any question or clarification. Okay. So thank you very much. We are back live now. So thank you to Edward for your excellent presentation. Of course, the data presented are opening a new scenario within these hemolytic anemias, thalassemia, sickle cell. So it's really, really an exciting time. So I'm looking to live Q&A, and I'm inviting any attendees to send a question to Q&A. In the meantime, I receive some questions that I try to select either for Vilma and Edward. I start with the PK deficiency, Vilma. I have a question. Will mutational status impact the clinician's decision to start treatment with mitapivat?
Thank you, Nika, for this question. This is really a key point because at present we have studied several patients, but the number of mutations in PK deficiency are more than 300, and I feel that they will increase as we search for these mutations. So the responders are generally those with missense mutations that are the less severe, the less disrupting the enzyme activity. And these are where exclusion, well, not having this mutation was an exclusion criteria studies. But anyway, we don't know what's happening exactly in vivo. We still don't know which is the impact of the mutation on the enzyme activity and on the enzyme stability. And we don't know even additional factors that may play a role, the ineffective erythropoiesis or the ability of the bone marrow to compensate. So mutation is, and of course, we have to study and to learn more on the impact of mutation. But as the treatment is well tolerated and the result, the improvement of anemia is very rapid, we have just to start and to try to use this compound because we don't know exactly before starting what will happen. And maybe the patient has some mutations that we still don't know in terms of not responding patients. So it's a matter of study, but not an exclusion criteria for trying to treat patients. Yeah.
Yes, thank you for this very clear answer. I have another question for you, and then I move to sickle cell because I'm receiving some questions. For you again, Activate T had the responders who were able to achieve transfusion-free status. What are your thoughts on the potential long-term impact of maintaining a transfusion-free regimen in this population? What are you expecting?
Well, the results from the previous study, we don't have such a long extension period in Activate T, of course, but the results of the previous studies are quite clear. When you have the response, you maintain the response. So we are expecting to observe the same responses also in Activate T. Yes, it is a long-term treatment. It's a treatment for life, but we hope that in these conditions we had nothing before this treatment, so it's really an improvement. And the previous studies that drive PK, so the first study, we have patients that now are 4-5 years on treatment, and they still have a good response. So we are confident for the future, but of course we will see.
We need long-term follow-up. Thank you. Yes. Edward, maybe before answering to one question who came for thalassemia, for you, voxelotor also increases hemoglobin oxygen affinity. What would you say mitapivat will behave differently than voxelotor? What is your thinking on this oxygen affinity?
Thank you very much for bringing this up. I think there are two major differences between voxelotor and mitapivat. First one is, I think, pharmacokinetic. So voxelotor binds to hemoglobin. So on a molar level, hemoglobin, of course, is the most prevalent molecule in the red cell. So you need a lot of drug to get there. And we know from the studies that they are not able to cover every hemoglobin molecule. So it's about 25 to 50%. So in contrast, mitapivat only has to target pyruvate kinase, which is much prevalent. I think it's It's difference in 2 logs. So you need less drug. But you're not able to 100% shift the oxygen curve because you only reduce 2-3 dpg. But so the difference is the one thing works stronger, but it isn't pan-cellular or pan-molecular. And the other one probably covers every cell and every hemoglobin molecule, but it may be less strong on the shift. So it gives more coverage, I think. That's my feeling. And the other one, I think, is the ATP bonus. So voxelotor doesn't do anything on the prevalence of ATP and all things which are covered by ATP. So this the oxidative stress response, but also the calcium pumps, which are so important to make the red cell perfectly hydrated. And we all know what happens when calcium goes up and Gardner's channel opens up. It's you destroy the red cell.
Yeah, thank you. I have a question from Sotirulla for me. Do you consider that the increase of hemoglobin to 1 gram will have a positive effect on the blood requirement or on complication of alpha-beta thalassemia? Well, Sotirulla, you know that it was shown clearly that anemia is an independent factor for comorbidities, and 2 recent papers by Khaled Musalam on American Journal of Hematology a few months or weeks ago showed that in a cohort of patients followed for 10 years, the level of hemoglobin goes straight in parallel to morbidity. And it showed that 1 gram was sufficient to modify the morbidity. So I think that we have to keep in mind that, and of course, if the response is higher than 1 gram, that will be definitely better. I have a question. Can mitapivat improve the DEXA score for the thalassemia patient who have severe osteoporosis? This is by Maria Adidemetriou. The answer is we don't know in thalassemia yet. I don't know if Vilma has any data on PK deficiency, but so far we don't have results yet. This is a question for anyone, I think, is a general question. Any blood clot adverse event with mitapivat? I'm assuming any thrombotic events was recorded during mitapivat treatment. Vilma, you have the longer and bigger experience. What can you say?
Well, yeah, regarding the improve in the DEXA score, we are aware we have no data on improvement, but we have no data about a worsening of the osteoporosis or osteopenia, which is a typical feature also in pyruvate kinase deficiency. We are still following patients. So I think that osteopenia and osteoporosis need really long periods of observation to see what's going on, if there is a stabilization, an improvement, or a worsening. I think that a stabilization would be also a very good result because of course, we know that this both these complications worsen with age. Regarding the other question, which was thrombosis, we didn't
coagulation.
Sorry, blood clots and thrombosis.
Regarding thrombosis, yes.
No thrombotic events observed. during the period. Of course, thrombosis is a concern in all hemolytic anemias because there is a close interaction between the thrombotic, the coagulation cascade and several mediators that are released during hemolysis, as everybody knows. And we observed thrombosis as baseline characteristic of PK deficiency patients, particularly in those splenectomized. But we know that splenectomy is, of course, a procedure who increases the risk of thrombosis in several conditions, including PK deficiency and, of course, others.
Thank you. I have another question for Edward. What has been the effect of mitapivat on clinical events like pain in the NIH phase 1 study? Are there data on pain effect?
So I wasn't an investigator on that study, but as I understood from Professor Tang, that so the VOCs, I think, are important to see what happened in the study. And so there weren't events on the highest dose level. There was one during dose taper and two during the dose reduction, and those the VOC event during dose taper prompted the study team to make a new tapering protocol because they taper too fast. So there was a responder with high hemoglobin, with low hemolysis, and then because the half-life of drug, I think it's about 12 hours or something, but it goes away pretty rapidly, and then you have a high hemoglobin without any protection, and then 2,3 GPG goes up. You have high viscosity with a bad P50, so you load off all the oxyhemoglobin, and then probably there will be an event. And then they make the taper a little bit longer, so 2-week taper, which is now standard in all the trials. And then they didn't see this anymore, only when the patients were off drug. And I don't think there was data on daily pain. So I cannot comment on this. I only want to highlight to the audience that on ASH, there will be a trial presented by a PhD student from my hospital. We also have a little bit longer follow-up on patients. And there we didn't see any crisis with hospital admission during the period we present. And also to come back to thromboembolism, I think there was a thromboembolism in the NIH trial. We have long-term follow-up data, and we haven't seen anything in sickle cell patients right now. But this will be presented on ASH. Abstract is already online. But no thrombosis also in our trial.
Again, of course, we have to underline that sickle cell disease per se is a condition, is a disease with high risk of thrombosis. So it will be always difficult to relate the events to the drug. Maybe you are asked, Vilma, an overall consideration. I mean, the question is, how do you see mitapivat fitting into the PKD treatment paradigm? So how could be a novel option? How you think about that?
Very good question. I'm not sure to have the precise answer at present because as you know, we had nothing but supportive treatment, which of course is good for patients, and splenectomy. Splenectomy is generally provides an increase of hemoglobin of about 1.6 grams. So it's not so effective as it is in other hemolytic conditions like hereditary spherocytosis. and increases the risk of thrombosis, of infections. So we are, if you look at how many patients underwent splenectomy in the recent years, comparing it with 20 or more or 30 years ago, the percentage of patients that accept splenectomy is decreasing, because there is, of course, an increasing awareness of the risks, thrombosis and infections following splenectomy. And the effect is not so good as in other conditions. Then we have also other treatment options like gene therapy, which is, we have a pivotal study which is it is doing something in the PK deficiency as in thalassemia with the gene therapy. But of course, there are several concerns about the gene therapy, and there are also costs, and it is not easy to perform. And so the setting where to put gene therapy is for the very, very, very severe cases who fail, I would say at this point, mitapivat, who fail splenectomy, who are transfusion dependent, and who fail also this drug. So we will learn in the real life, which will be the setting of this drug, because at present we have only trials, and we have not the real life experience, which is the experience that gives the right position of a drug in the clinic, in a disease which is so heterogeneous as it is PK deficiency, with some cases quite without any problem, and some other with really a burden of disease.
Yeah, I agree with you. I mean, considering a disease where the options were very limited and in some way demanding, like blood transfusion, splenectomy, I think that is definitely a step forward, is an improvement. Of course, we need to have a larger cohort of patients and long-term follow-up. On the other hand, what I always consider, and that's also I do for the clinical trial in thalassemia, we may probably learn more from the real life than from the clinical trial. So clinical trials are always, very close in some way, imposing some criteria. In real life, the let's say clinician expertise, knowing the patients, the drug may be adapted. This is, to my point of view, the personalized medicine, and I'm sure we are going to learn more and more. I have now a couple of questions left for me. One is, I don't know if it is again Sotirulla, but I don't know who is posing that. Are there any specific genotype that may be more likely to respond to mitapivat? The answer is, I don't know. We don't know yet. With the two ongoing clinical trial, with a large number of patients, because the phase 2 was enrolling only 15 beta thalassemia patients, we cannot really have any answer. What is impressing me, although are few patients, but the 5 alpha patients responded 100%. All of them responded properly. And this is interesting because in some way the pathophysiology of, or let's say the metabolism of erythrocytes in alpha thalassemia is a bit different. So I'm very interested to see how they will behave. And I want also to underline, for those who are interested in thalassemia, so far, this is the only drug in clinical trial, including alpha thalassemia. We have several compounds, several trials ongoing, but all on beta thalassemia. And this is the only on alpha, which is quite promising. I have another interesting question, and I think will be the last because time is running. Any data for an effect on iron overload based on mechanism? Would you anticipate an impact? Well, this is a very, very interesting question. We don't have data in vivo, so in the clinical trial, also because the period was very short to see any potential change in iron overload. However, we have data in mice model of thalassemia. There is a paper already published by Professor De Franceschi who looked at the response of mitapivat in thalassemia mice model. She found an improvement on ineffective erythropoiesis with an increase of hemoglobin. And the improvement of ineffective erythropoiesis goes, or at least maybe independent, I don't know, but also she observed an initial improvement of iron overload. This is not really surprising, as this was observed also for other compounds targeting ineffective erythropoiesis. I see Edward who is raising his hand, so if you have any comment.
Yes, I totally agree with you, of course. And I just want to extend this a little bit with what we found in the pyruvate kinase deficiency trial, because we did a post-hoc analysis on hepcidin, ERFI, and EPO. And what we saw is that patients where hemoglobin who were on drug, so not only responders, but just on drug, we saw a drop in EPO, we see a drop in ERFI, we see hepcidin going up. So we really think that at least in PKD, we see things happening in iron metabolism. So that I think
is very interesting. And as far as I know, Vilma, in PK, you have a high level of iron load also. So that will be...
Yes,
yeah.
Absolutely.
You want to comment?
Ferritin, which is very high, not only in transfusion dependent, but also in non-transfusion dependent patients because of ineffective erythropoiesis and a lot of other mechanisms involved. But of course, we will see with extending the observation, because at present, of course, our chelation is performed as for good clinical practice in all patients that have iron overload, and we cannot, of course, at present stop iron overload. But in patients who have not yet iron overload to be chelated, we observe very good, nice data, and in the future maybe we can confirm that the drug is able also to act on this aspect of the disease.
Thank you. I think we are perfectly on time. We had, I enjoyed the discussion. I hope the attendees did also. And I want to, of course, to thank once again Vilma and Edward for their wonderful presentation and very live discussion. And I thank you all for attending this session, which was supported by AGIOS Pharmaceuticals. With that, have a nice evening and enjoy the meeting tomorrow. Bye-bye to everybody.
Bye. Bye-bye to everybody. Thank you all.
Bye. Thank you. Thank you. 1, 2, 3, 4. Shares. I did. Yes. Yes. Condividi. Yes. So I open just one I have here. It's not the one I'm going to use tomorrow. No. Okay. 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 Wait. Okay. Main stage. Okay. I push the share screen. They said here condividi. Condividi. So condividi. Now I have to, and then I have to open my PowerPoint. To do that, I do like this. I will leave it on my screen so it will be quicker because I have to open. I open it. Yeah, I'm doing that. I will leave open on the screen so it will be quicker because now it's